So hyperlipidemia. When we talk about hyperlipidemia, we'll get into more detail with this a little bit later. But there are several different things that this could mean with several different things in our body. So I'm going to breeze over a lot of this stuff that's pathophys-wise. I fixed it. I tried to call you. Sorry. I got it. Thank you. And I will tell you where we start to get testable. So a lot in Pharm 2, what you're going to see is I'm going to say this is just background. It's not testable. Okay, so a lot of the pathophys, if I forget to say it, pathophys, I don't ask you about that. There's very rarely where I'm going to say, hey, pay attention to this because it's going to directly tie into like the mechanism of action of a drug. But I don't test you on pathophys. I'm not teaching you those things. It's just so that you can have an idea of kind of how some of this stuff works because you haven't seen some of it depending on which class you're in, okay? ELOs, same things. Remember, mechanism of action, adverse effects, all those things, the drug class, paying attention to those. These are all the meds that we're going to talk about. So you see you have your statins, your fibrates, niacin. We'll talk about the different forms that we use, your bile acid sequestrants, cholesterol absorption inhibitors. You'll also see those abbreviated as CAI. Your PCSK9 inhibitors, omega-3 fatty acids, which some of these they can get over the counter without you. And then your Metamucil, which we've seen lots of commercials and things for those, okay? So really quick, what do you know? What is the drug class of choice for someone who has a high level of LDLs? Statins, right? True or false? Statins can be taken while someone is pregnant. True. Over there. True or false? You think yes? Oh, but it's okay because we're about to learn this and we're going to know that, okay? What class has, now there are very few, we're not false, okay? I'm not going to go that deep. All right. What class has the most triglyceride lowering effect? Yes. Fibrates, okay? So these are the ways when you're going through this and you're going through this lecture, these are the ways that I want you to kind of pay attention to things, right? Because the indication is going to be hyperlipidemia, right? So all the drugs that we talk about, these are several drugs that you can use for hyperlipidemia. But I could have issues with my LDLs. I could have issues with my triglycerides. So it depends on what you're targeting that is causing the dyslipidemia, okay? So it's not just meaning that I had high cholesterol. That's not always the case, all right? All right, non-testable material. This is just background things for you to know. So we need cholesterol. We also have triglycerides, and these are both things that are not soluble in water. So if we have a buildup of these things in our body, that can cause that dyslipidemia. And then we have issues, right, where we're trying to have now cardiac issues. So there's several different things that can essentially happen if our body is not regulating this properly. Or if we ingest some of this, we can also get by eating poorly. And then some of this is also genetics. So when you have a patient that comes in, don't automatically think, oh, they're out of shape. Oh, they're not healthy. There are some people that we have that come in and they honestly earned it, right? Genetically, that was in their family and they have familial hypercholesteremia. Okay, we had a patient, he was in his 20s, he worked out every single day and he looked like he worked out every single day and his LDLs were atrocious. They were horrible. And he was also super sensitive to statins, so we couldn't give him statins. So we had to go down this whole road of how we were going to dose him and stuff, and it was an interesting thing to see, but it also made me realize, like, everybody is not out of shape. Everybody does not present in a certain way that looks like they have bad LDLs or their triglycerides are out of whack, okay? So remember that when you see them. Don't judge a book. Don't judge a book by its cover. Don't drug anybody. It's not good, okay? Go to jail. All right? So this is just telling you the same thing I just told you. There's different ways in which I can get that cholesterol, right? Endogenous means that my body naturally makes it, right? It's in-house, endogenous, versus exogenous would be like the things that I ate if I have a poor diet because I like to eat McDonald's every day, right? So that's exogenous. but most of it is coming from our body making that cholesterol. So what you see here is something that is going to kind of come up, and we'll look at it a lot when we're talking about the way that our drugs work, because we like to use our statins more. This is what you're seeing. So you see your acetyl-CoA, and essentially, long story short, right, acetyl-CoA ends up getting to the point to where we make cholesterol, right? This is our end goal. This is how our endogenous cycle is going to work. This is increased at night or when the patient is sleeping. So a lot of the times with our statins, depending on which one we give them, we tell them to take them at night because that's when most of our cholesterol is being made in our body. So that's another thing for you to remember. But this entire pathway here ultimately is going to lead to us making cholesterol. And with our statins, which is the drug that we love the most, we're targeting that HMG-CoA reductase. If we can stop that, and you see very early on we would be stopping that, then we prevent that increase in cholesterol that could be occurring in our patient, okay? So that is our goal. Our target for our statins are HMG-CoA reductase. This is just telling you that there's different types of lipoproteins that could be, bless you, targeted or something that we are monitoring. So you have your VLDLs, or your very low density lipoproteins, your IDLs, your low density proteins, and this is what we typically talk about when we say LDLs, and LDLs are bad. They're real low, okay? They're bad. And then your high density lipoproteins, right? They're high, they're up there. These are the good ones. These are the ones that we want to see a high number. All of the other ones, you want your numbers to be low. But we don't give medications to increase this number, okay? So you'll see some of our meds that we're gonna talk about, as a byproduct, you will see that, oh, it increases HDL. But if somebody has a low HDL, you won't just tell them, here, take this med. You're going to tell them to do other things to increase their HDL, okay? Y'all will learn about that later. So this is just giving you different definitions. Again, not something I'm testing you on. Some more terminology, still not testing you on any of this. So this is just looking at anything that you talk about that is an abnormality in a lipid is considered to be bad, all right? So when you look at your hyperlipidemia, this is saying that I have hyper, right? It's up. Hyperlipidemia, high concentration of fat or lipids in the blood. Whereas dyslipidemia, it could be either of these things that are happening, okay? So the terminology does matter. Whenever I'm testing you on the exam, just know what I tell you we're targeting so that you know which drug of choice you're using is the name of the game for this part of it, okay? This is just showing you essentially what happens when somebody has atherosclerosis. This is what our stable plaque looks like. So this here is essentially all of those lipids, they kind of packed in there and they're stable. They're not moving. I don't think that they're going to break off. They're going to rupture or do anything. But you see now I have occlusion in this vessel. It's not how it should be, and therefore now I have an increased risk of having some type of cardiovascular event. This one, it looks better, but it's not better, right? It looks like it's open, but now I have this ruptured plaque that happened, and now all of these things that were in this plaque that was once stable is now floating throughout my body and could potentially occlude somewhere, which would cause me to have like my MI or all those other things that are horrible that could happen. Okay, so plaques are things that we don't want, and there are several ways for you to measure that. We have our blood test. You can also get a CAC score, and that's something that cardiology usually does if you want to refer your patients to see if they have any type of predisposition to having any of these types of clots or plaques occur. All right, this is where we're starting for our exam. I care about meds, right? So when we talk about Pharm 2, you're going to hear us talking about a lot of different guidelines. And when you see a guideline is something that is guiding you. Does that mean that that is always what you have to do? No, but that is what we have the most research in, which is why it's great for you to do what is in the guideline. Sometimes you will also see that there's more than one guideline for a disease state. So when you talk about asthma, you will see that there are more than one guidelines when we talk about asthma. So when we're looking at our lipids and different types of guidelines that you can use, You see ATP3, and then we also have AHA and ACC. The guidelines are not the same. Some are more strict, some are less strict. Some will vary depending on that patient's age versus not. When we look at this, it depends on what you prefer once you start practicing. The other thing with this is that these get updated frequently. Your PANCE is not going to update as quickly as we would have information to update our slides. So there are some times where if a new guideline comes up, you guys will still be taught the old guidelines, because that's what, by the time you hit the PANCE, that's what they're going to test on. So you could potentially get to phase 2, a new guideline drops, and then everything that I taught you is outdated, okay? That is what happens with guidelines. And some of them are updated every year. Some will have minor changes, and some it's like it changes your whole practice and how you would be treating a patient. Older docs will be like, I don't care about that new guideline, I'm still doing that thing, okay? They're not wrong. They probably are a little wrong. They're not wrong. It's just sometimes we get stuck in how we do things, right? So it's up to you to be like, hey, have we seen the new guideline that says da 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 da, whatever, what have you. Okay, so this is just showing you that there's 2 different types of guidelines that you can see, one being more stringent than the other. Not going to ask you this as an exam question, because I'm not expecting for you to memorize guidelines. What I do want you to remember, until we get up to date on the newer guideline, we have something that's called an ASCVD risk calculator. And essentially what this is saying is that you're going to go in and you put in all of this information into this calculator. And what it does is it gives you a 10-year risk of somebody having some type of cardiovascular event based off of all of the information that you will input. So you'll put in their gender, you'll put in their sex at birth, their age, their race, all of these different things. This is all coming from your labs, right? So their cholesterol, HDL. If they're on any type of treatment, just because someone has hypertension does not mean that they're actually taking the medication that you have prescribed for them to take. So make sure that they're actually taking meds, and then you can answer, are they being treated, are they not being treated? Their blood pressure, do they have diabetes or not? Are they a smoker or not? You're relying on them to be honest with you. And then you will take that information out of the calculator, talking to the patient and say, do you feel like they need therapy or not? Do you need to put them on a statin or not, based off of what risk came out of that calculator? This does not mean that they have had an event yet. Sometimes they may not have had a cardiovascular event. This is something that we're prophylactically trying to do to make sure that they don't have a cardiovascular event, okay? We're trying to get those LDL levels back into a range. We're trying to get those triglyceride levels back into a range that is tolerable and decreasing the risk of them having a cardiovascular event, okay? So this is a super simplified way to look at the next chart that we're going to talk about, that I will not give you, and we're going to remember the next chart. But this is a great summary for you to see what the next chart is saying. So, clinical ASCVD, an LDL over 190, or an ASCVD risk score that is greater than 20%. This came from the calculator. The calculator will spit out a percentage to you. So an ASCVD risk that's greater than or equal to 20%, and they're over the age of 40. We're considering 40 to be old in this situation, okay? So over the age of 40, they get a high intensity statin. This is what you would treat them with, okay? So any one of these 3 get a high intensity statin. We're going to talk about the intensities of the statins and all that good stuff in a moment, okay? So they have ASCVD, LDLs over 190, or if they're greater than or equal to 20% on that risk calculator, they put it in, and I give you a percentage, right? Because I'm not going to tell you to put anything in on the exam. I'm going to tell you what their percentage is. And they're over the age of 40, then we're going to say, hey, high intensity statin. When you're looking at this moderate intensity statin, these are going to be your patients who are, again, 40 to 75 years old. But what you see here is that these patients have diabetes, or they have ASCVD risk scores that are greater than 7.5% but less than 20%, okay? Now, when we look at diabetes, and when you guys learn about diabetes, diabetes exposes people to several things. okay? They're more likely to become ill. They're more likely to have lots of issues. So if we see somebody that has diabetes, one, we want to treat it, but two, we need to make sure that we can prevent any other diseases that are happening. So just the fact alone that this person is this age with diabetes, we're already saying, regardless of anything else, that they are getting a statin because they have diabetes based off of this guideline, okay? Or you see the ASCVD greater than 7.5 but less than 20, because if they were over 20, what am I giving them? High intensity statin, okay? Also, if you're reading anything and you see that they have an LDL score that is greater than 190, high intensity statin. What if my patient had an LDL score that was greater than 190 and they had diabetes? High intensity statin, right? I want to go more aggressive and treat the thing that, like, go with the more stringent law, okay? So give them the high intensity statin versus giving them a moderate, because now with the high, I'm covering both, okay? So any of these three, high intensity, this moderate intensity. Most of our patients these days, they get high intensity, okay? All right, now this chart. I will not give you this chart. You're going to remember this chart, okay? But this chart is a summary of what I just showed you on the previous slide without all of the boxes, all right? So remember I told you if their LDL was over 190, right? Greater than or equal to 190, what did they get? High intensity statin. That's this. If they had diabetes and they were 40 to 70, we said they got what intensity? They got a moderate intensity statin. There are your two that you have right here. Now, when you see these yellow boxes, this just means that it's in a different class of recommendation. So when they did the study to come up with this guideline chart, they get a panel together of all experts, and this is like a class 2 recommendation. I don't want you to remember the yellow. I just want you to remember what's in green, okay? It's just telling you that you could potentially consider a high intensity statin in this patient, but I want you to remember moderate because we like black and white for our exams, okay? All right, now, if they're over the age of 75, then you have a discussion. This is very important to remember. I'm close to being on my way out, right, at 75. Am I going to remember to take something every day when I didn't remember to take something every day when I was 40? Maybe not. Maybe I will because I'm trying to hang on. We don't know. But when we talk about statins and you look at the adverse effects that we are going to see with our statins, this is why in our patients who are over the age of 75, we're very cautious with using them, or we will try to use as low a dose as we possibly can because they're more prone to experience the side effects with the statins, okay? So this took all of this side for you, okay? High intensity, moderate intensity, discussion. I'm over 75, discuss it with me, give me a choice, okay? Now, when you go over here, this is when I would have to give you an ASCVD risk score. Even if I gave you one of these patients over here and I told you that their ABCD risk score was 5%, it doesn't matter. You still need to follow what's over here, right? The more stringent law is what we're following, okay? So then at that point, in the vignette, the ASCVD risk score doesn't matter. It's irrelevant if I tell you that one of these things is going on. Or if I tell you that the ASCVD risk score is 20, now your ears should perk up and be like, I need a high intensity statin, okay? So sometimes in vignettes, you will see a percentage and you don't even need it because you already have something that's telling you what you need to do, okay? So don't get confused and say, well, they didn't have like their ASCVD risk score was like 5%. Cool, but I also told you that they had diabetes, or I also told you that their LDL was extremely high. Pay attention to that too, okay? That would be your first thing. You're gonna treat more stringently than being like, oh, let's wait until they have a heart attack, all right? We don't want that to happen. That's what we're preventing, okay? So this is saying, hey, my patient that is 0 to 19, most of the time these patients will go to a specialist. There are usually some type of familial type of issues going on. Not going to ask you anything from this, so don't worry about this one. But you will see there are some younger people who are on statins, and it's because, again, genetics and all of the things, and sometimes random mutations where you'll see this happening. 20 to 39-year-olds, not going to really ask y'all that, so don't worry about it. If I give you somebody like this, they're going to be like out of the park with their LDLs or something crazy. This is usually where you'll see exams asking you questions. So you're 40 to 75-year-old and your LDL is greater than 70 but less than 190. Because if I was over 190, what are you doing? A high intensity statin. So this is boxing you. The reason why this says greater than or equal to 70, less than 70 is our goal. That's where you want to see people's LDLs, okay? So you want my LDL to be less than 70. If it is not less than 70, that's why you see that cutoff happening there. And then your range hits 190, because if I'm at 190, you need to get me back in range, and you're going to give me a high intensity statin anyway, okay? So that's why your range says 70 to 190. And then they don't have diabetes, because if I had diabetes, where am I going? Moderate, if that was all that was wrong in the perfect world, right? Most people are going to come to you with several things, okay? So what you see here is you have less than 5%, 5 to 7%, or 7.5%, 7.5 to less than 20, and then greater than or equal to your 20. Now, your low risk, less than 5%. This is just a conversation that you're having with a patient, okay? When we look at this, we're always enforcing or trying to make sure that we're talking about lifestyle modifications always. Are they eating right? Are they still exercising? Did we get them to stop smoking? Because all of these things are increasing that risk. Is their diabetes managed and they're taking their medication? Is their hypertension managed and they're taking the medication? Anything that leads to the path of making their heart not work properly or clogging their arteries, we want to minimize in this disease state. I mean, in general. But specifically for what we're talking about, we definitely want to make sure that we're minimizing all of that, okay? So less than 5% lifestyle discussion, talk to them, working out, all the things. 5 to less than 7.5%, these are your borderline risk patients, right? So this says if risk enhancers are present, then you're going to talk about giving them potentially a moderate intensity statin, blah, 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 blah. I'm not asking y'all about either of these two right here, okay? I'm not going to ask you about low or borderline. I'm going to hit somewhere over here, likely, because this is where most of your people are likely going to be. Okay, so here we have our patient is between the age of 40 and 75, and I tell you that they're greater than or equal to 7.5, but they're less than 20%. That's their ASCVD risk score that came out of the calculator, okay? So if that is the case for this person, all you need to remember is moderate intensity statins, okay? That's what we're gonna give that patient. If they're greater than or equal to 20, then you hit that high intensity statin. You're gonna pick one. Okay, I'm not going to ask you about these two, so don't worry about those two. You're low in your borderline risk. On this chart, these are all of your risk enhancers. I am not going to put one of these to make you remember a risk enhancer. If I give you this and you see an ASCVD risk score that is between that 7.5 and 20, then just know, okay, this is a moderate intent. I'm not going to make you try to remember all these because we're not going down that path, okay? All right, so everybody good. This is the summary, essentially, of the primary prevention chart and the pathway in which you're going to go down the primary prevention chart. Now, what is one thing that you have noticed? So we have a low intensity, moderate intensity, and high intensity statin. Did we see a low intensity statin anywhere? No. And we'll talk about low intensity statins. We don't use them a lot because they're barely touching the surface. Okay, like it doesn't do a lot for your patients, but there are circumstances in which we'll use them, and so we're going to talk about that. But if you see a low intensity statin on the test, unless you see some type of on your pants, any test, unless you see some type of extenuating circumstance that we're going to talk about, you should never really pick those because they're not going to do it. It's like giving a whiff of a statin. And just think about us as being unhealthy people, okay? Now, your secondary prevention. Secondary prevention is saying that this has already happened to me. I already had some type of cardiovascular event happen. The time frame could vary, but now we're secondary prevention. I missed my primary chance for me to prevent this thing from happening. Now I'm in a secondary prevention. This black box, I want you to remember these things that are in here. So they had some type of your very high risk patient, and then you have ASCVD, but not a very high risk. So example of a question, your patient has been diagnosed with ASCVD, and if that's all it said, then they're not a very high risk patient. If I said your patient is diagnosed with ASCVD and they recently had a stroke, that is a very high risk patient, okay? They recently had a MI or a heart attack, right? So this is a very high risk patient. So understanding the difference between the two is what happens here. So secondary prevention, I'm like, oh crap, they've had this thing happen to them, okay? So now we're behind the 8 ball, all right? So if they're less than or equal to 75, high intensity statin. They are already at risk. They have already had this happen to them. I have to be aggressive, okay? Now, if they're over the age of 75, it depends on what's going on. Before with primary prevention, right, we were talking about a conversation. We could talk about it. Here, you see that it's yellow, which means that it's still a class 2 recommendation, but it is something that we are now definitely considering, and most of the time we will start with a moderate intensity statin before going to a high intensity statin, depending on when they had that the ASCVD risk or the ASCVD event happen. The reason, again, why we'll do a moderate to see if they can tolerate the statin before we would go up to a high. Some providers, they're like, you know what, I'm going to start high. I'm going to protect my patient. They're already older. They already had this event. I'm going to start high, and then if they tell me they can't tolerate it, then I go low. Okay, so I'll drop it down to a moderate intensity. So for the purposes of this, know if I am less than equal to 75, I'm going to hit them with a high intensity statin because they already had it. Secondary prevention. They already have ASCVD. When we were looking here, they didn't have ASCVD. Okay, they were at risk of having it, and we are trying to prevent it before it happens. Versus your secondary, I have it. Now you're playing catch up and you're trying to make sure I don't have another ASCVD risk or the ASCVD event. Okay? You want to protect me now because I'm at risk. Okay? But I'm not older than 75, high intensity statin. When you're looking at this, I want you to look at this flow chart because I'm going to oversimplify this flow chart too. So high intensity statin, if for whatever reason they can't tolerate a high intensity statin, it only makes sense to go to a moderate intensity statin, right? Because I can't tolerate high, drop me down. And if that doesn't work, we're going to talk about this drug class. But if that doesn't work, then you can add ezetimibe. Don't worry about the numbers. I'm not going to ask you the numbers and go into the LDLs. I just want you to know I'm starting with a high intensity. I can't tolerate the high intensity. What do? You drop me to a moderate intensity. Or let's say I'm on the high intensity, right? You're still not getting control of me. I can add ezetimibe to that, okay? So that's my second thing that I need to do. If you can't get me to goal, right? I'm on the maximum dose of the statin that I can get, and my LDL goal is less than 70, and let's say I'm still at 100. And you're like, okay, Raina, are you still eating at McDonald's? Are you taking your medicine every day? Like, you're trying to get to the root of the problem. You can say, all right, cool, I'm going to add ezetimibe to your regimen and see if that can get us down to our goal of less than 70, okay? So this is us chasing 70, right? We're trying to get them below or equal to that 70. So high intensity statin because I'm less than 75 years old, less than or equal to 75 years old. Okay, if I can't tolerate it, moderate. Let's say that you have me on a moderate or a high and I'm still not at my goal of less than 70, then you're adding on the ezetimibe. Okay, so I could be on 2 medications to get me to my LDL goal. This is over the age of 75, so again, it just depends on the provider and what they want to do. Do they want to go moderate? Do they want to go high and then drop down to moderate? It's up to them. I've seen both ways. Now, very high risk, I need you to remember the black box here, okay? So your major ASCVD events occurring. So I'll tell you if they have acute coronary syndrome, and I'll tell you if they have ACS, I'll tell you if they have a myocardial infarction or MI, I'll tell you if they had a stroke, I'll tell you if they have peripheral artery disease, I'll tell you what they have. Or if they had a ASCVD, a history of ASCVD, right? So they've already been diagnosed. And they're greater than 65. They have a history, so familial diagnosis. They have diabetes, or if they're still a smoker, then I also consider these people a high-risk patient as well. So if you see any of that in the vignette, this is now your very high-risk patient. But look, we still have the same thing. I'm giving them a high-intensity statin at the maximum dose. If that doesn't work, I add ezetimibe. What I could also do is, and usually we go in this order, even though this is class 2. We'll start at high intensity, we add ezetimibe, and if that doesn't work, then you can see where we go to the PCSK9 inhibitors. Our PCSK9 inhibitors are very expensive. It depends on if we choose to use these or not. Most of the time when we use the PCSK9 inhibitors is because someone has a familial history, is typically when you'll see us kind of go to these, and they can't tolerate a statin very well. So high intensity or your maximum intensity statin, you also have where you can do your ezetimibe, and then you see your PCSK9 can be added as well, okay? Don't worry about these two over here, this dash, whatever this is talking about, cost effectiveness, and then over here when you're looking at the lowering, don't worry about that as well, okay? Are we all okay? Don't laugh. We're all right. We're all right. Okay, so when we're looking at our hypolipidemic agents, what this is saying is, right, my patient had hyperlipidemia up, and I'm trying to get an agent to bring it down. So these are all of the different drug classes that we have that fall into that category of trying to lower their lipids, right? So I have statins, which are targeting that HMG-CoA enzyme reductase. I have the different things that can alter how my lipids are being broken down or metabolized. So I have niacin, fibric acid derivatives, or my fibrates, PCSK9 inhibitor, and my fish oil. I also have bile acid sequestrants. These we don't use as much anymore, but they're still very helpful depending on the condition of the patient. We'll talk about that. And then your CAI, which is your ezetimibe that we kept saying, like, hey, if my statins aren't working or if I'm still not getting to goal, how can I bump them a little bit over the edge? And that's your ezetimibe or your Zetia, okay? Now, this chart is a very helpful chart because it helps you know which drugs are targeting which lipoprotein. So when I'm looking at this, I have my LDL. The best drug that I have for my LDLs are going to be a statin. Second to that is my bile acid sequestrant, right? HDLs, I told you we don't prescribe medications for this specific reason, but this could be a benefit for a patient who is using niacin, right? Because niacin has a great bump in their HDL for the patients who are using it. So this isn't necessarily something that we're going to treat in a patient because they have low HDL. We're like, okay, diet, exercise, different foods that they eat. We won't give them a med for this. Now, triglycerides, right? So this person has elevated triglycerides. My best thing that I have for triglycerides are going to be my fibrates, okay? So pay attention to what issue your patient has because your answer is not always a statin, right? Does my statin decrease triglycerides? Sure. But is it decreasing it as much as I would want it if I had somebody who has high levels of triglycerides? Not better than a fibrate. So my fibrate would then be the thing that I'm choosing. Okay? So make sure that you are distinguishing on any exam what you are trying to treat. So this is essentially a drug of choice slide, right? Drug of choice for LDL is my statins. Drug of choice for my triglycerides are my fibrates. What if I had a patient who has both? Could they potentially be on a statin and a fibrate? Sure, right? There are some people who are on several things, all right? Because we still can't get them to go. There's some times where I can put my patient on a statin and maybe their triglyceride level isn't super, super high, and so it can drop them just down enough to goal, and that's okay. And I don't have to add on another drug. So it just depends on your patient, and when you put them on these meds and you bring them back in for labs for their follow-up, you see how their numbers are trending, and you're like, okay, this might be a good enough dose, or maybe it's not, right? So big takeaway from here, statins, you're targeting LDL, fibrates, you're targeting triglycerides. Niacin is good with triglycerides too, but niacin has a horrible side effect profile, and a lot of people don't stick to it because they have a lot of flushing, they turn red, lots of things with niacin. The dose that they need to take for it, most people can't hang in there for this. So most of the time for triglycerides, we're going to stick with our fibrates, unless someone can't take it. Okay, this is a short lecture, but it requires a lot from your brain. You are going to need to remember these intensities for these statins, and I'm going to help you remember the intensities for the statin. But this is important for you because you need to know the intensity because it varies based off of the dose. There's the same drug that can go across several different intensities, but it's the dose that changes the intensity. What I mean by that is you see atorvastatin 10 to 20. So what's in parentheses is just telling you like what they studied versus what they didn't. Depending on what guideline you use, you will get different answers for this, like different charts where what's in moderate intensity and low intensity might shift a little bit. Use this chart, don't use an outside chart because again, you could get different things depending on what chart you use. So when you look at this, you have high intensity, moderate intensity, and low intensity. You kept hearing me say that. Low intensity statins are the ones that we don't use as much, but we're trying to decrease their LDLs by at least 30%, right? So that's the number that you see here. This is the LDL lowering effect that medication will have. So that's why I said this is like a whiff. Most people, by the time you catch them, they're well over needing a low intensity statin, okay? Moderate intensity, 30 to 49%, and your high intensity is over 50% is where you should see that reduction happen, okay? So high intensity, what I was trying to tell you was you see atorvastatin, it says 10, and then in parentheses you see the other dose that was used, and this is again what was in the study. So this is essentially a range that says 10 to 20. 10 to 20 is your moderate intensity statin. But if I double that and I hit 40 to 80, that is a high intensity statin. AR is a high powered weapon, right? High, that's how I remember it. I don't know. And so 40 to 80 is your high intensity for your atorvastatin. Rosuvastatin, you see it also in both, right? But here it's 5 to 10. Again, double it, 20 to 40 is my high intensity, okay? So these are your high intensity. These are the ones that you're going to use a lot. I talked to you earlier about where most of our cholesterol is being made at bedtime when people are sleeping, okay? What you see here in these patients who are taking a high intensity statin, because it's a high intensity and the duration and all the PK parameters that surround it, we don't care if they take it at night, during the day, whatever, it doesn't matter. So that counseling point no longer matters for those patients who are on a high intensity statin. But if you have somebody who is on a moderate or a low intensity statin, we still tell them to take it at bedtime, okay? So here you have your atorvastatin and your rosuvastatin. You see that they were half the dose of our high intensity. Your simvastatin, when we look at this, we don't use our simvastatin as much anymore. It doesn't have as great of a side effect profile as we see with our atorvastatin and our rosuvastatin. But it is still a popular one that you will see. So above the line are the ones that are more commonly used, and then the ones that are below the line are the ones that aren't as commonly used, so that you can see how we're breaking this up. But this one is, depending on the provider and who you talk to, we don't use this as much. We'll use usually our atorvastatin or rosuvastatin, and then again, those strengths vary on if we're hitting a moderate intensity versus a high intensity. You also have your pravastatin, lovastatin, fluvastatin, XL, and then your regular fluvastatin now because they're having to take it twice a day. So if you just remember your fluvastatin with the dose of being between your 40 to 80, because this one gets kind of tricky because you see here fluvastatin low, you're just taking it one time, but I'm not going to ask you all of that. It will be obvious when you see it. And then your pitavastatin 1 to 4 milligrams that you have here. So when I talk to you about the statins, or when I give you a question about the statins, because you need to know the intensity, I'm going to have to give you the strength. Okay? So this is one time where the strength of stuff actually matters, because now you need to know it to figure out where this goes, right? If you don't know the strength, then you don't know where it goes. So remember to look at the strengths on this slide, because it matters. Most of the time I tell y'all don't worry about it. This time you have to worry about it, okay? Now, your simvastatin, again, low intensity, not used very often, but what you see is that you have, again, half, so half, multiply by 2 is how these keep going up, right? Multiply by 2 to get up here, and then these two you multiply by 2 to get up here. So your simvastatin 10 is typically what we see in our low, but again, side effect profile, not great. You have pravastatin, lovastatin, and your fluvastatin. Again, you see that these doses are essentially in half of the upper range. And then this one, the difference is that they're not taking it twice a day, they're just taking it once a day for that low intensity stat, okay? So just remember you're doubling once you go up, and that you only have an AR in high. Your atorvastatin and your rosuvastatin are the only two that you have for a high intensity stat, okay? So what I would suggest is what I always tell y'all: remember the high, remember the low, and then everything else is in between, right? If you remember that, because this less here and less here than this, all right? But I know some of y'all like to remember everything. Also up to you, okay? Now, when we look at this, our mechanism of action is essentially in the name, right? HMG-CoA reductase inhibitor is going to be your statin. That is what it is targeting. When we saw that pathway, that is what we saw being targeted, right? So when you inhibit that reductase, essentially what you're doing is decreasing the amount of intracellular cholesterol that person has hanging around. What then happens is your body is like, hey, I need to upregulate my LDL receptors. What does that say? Here. Upregulate my LDL receptors that can bind anything that is circulating in my body, right? So if I upregulate, that means I'm trying to bind to that LDL that's floating around in my body, trying to cause havoc, okay? So if I upregulate, now what I have done is decreased the plasma LDL, which is what we want, because they have too much floating around. So I want to upregulate those LDL receptors. I'm blocking that reductase, so therefore I'm stopping that cascade from happening, and I see a drop in their cholesterol. I see a drop in the LDL, okay? We already talked about this. If somebody has high levels of LDL, we like this as our drug of choice. And then this is just for somebody who has chronic heart disease, or if they're at risk for heart disease. We usually will use some of these medications because, again, it's trying to make sure that we're covering all of our bases. It's a prophylactic type of thing. And then not approved for kids that are less than 18 years old. Now, I will tell you that you can see this. Are you going to likely touch this? No. But again, some people who have like familial issues, things like that, sometimes we still have to put on a statin for those patients to control them and get them down to less than 70. But it's not common, and it's an off-label thing. I'm not going to ask you about that. Looking at our effects, again, same thing that we already saw here, right? Decreasing the LDL, that's what we know it mainly for and what we prescribe it for. You also see that I can decrease mortality. Anytime you see a mortality, morbidity benefit, exams love to ask you that. Me, Pants, everybody at IPAP, we like to ask you about that, because that is preserving life. That is what we are trying to do, right? And so if I can decrease mortality, that is a big deal. If I can decrease any type of cardiovascular event, which is what we're doing with these medications to decrease their LDL, that is a big deal, okay? So that's what this is essentially saying, right? Decreasing how much work you will have to do on someone if they have an event, right? Coronary procedures, this is if somebody ends up where they have to go into the cath lab for whatever reason, like y'all will get into all that stuff in cards, but very great drug, and we like it. Looking at the evening administration, we already talked about this. Make sure that you're giving it at night because most of our cholesterol is coming at night from our endogenous pathway versus what we're eating. But if I have a high intensity, so that's where you see your atorvastatin and rosuvastatin, but this is only your high dose. If you have your high intensity, it doesn't matter what time you're taking it, okay? And then looking at this is very important. So you are not going to change a dose until someone has been on it for at least 4 weeks. If you just gave me the meds and I came in and you took my labs again and you're like, oh, your LDL is still trash, Raina, what are you doing? Well, I've only been on my meds for 2 weeks. Well, you prescribed them 2 weeks ago. I also left them at the pharmacy. I haven't even picked them up yet. That's why, right? Or I picked it up, but it's only been 2 weeks. My body hasn't caught up yet, right? So you have to give at least 4 weeks before you say, I'm changing something because of a lab. Now, these adverse effects could make you change something before that 4 weeks, okay? Depending on how that patient presents. So you'll see a lot of muscle issues happening with your patients, okay? So myalgia, which is the muscle pain, myopathy, they could have cramps, they could have pain, they could have weakness, bless you. But what you're seeing here is the CK or their creatinine kinase, which is something that is very important that you're going to monitor when you start a patient on a statin. You're going to get their baseline, and then you're going to monitor their CK, because if it goes to greater than 10 times of their upper limit of normal, then you're likely going to have to discontinue the medication, decrease that dose. Depends on what else happened when they did it. Most of the time we can get away with stopping it for a little while, letting those numbers drop, and then we'll go back with a moderate intensity statin for them. Or we'll do other things like we'll tell them take it every other day, things like that, which we don't love to do. So monitor the CK baseline like I just told you. You can also see where somebody has rhabdo. Again, same thing, we're monitoring the CK. I don't need you to remember the 10 times the upper limit or 10 times. I don't need you to remember all that. Remember what you are monitoring, okay? That is what is very important. You need to have it at baseline, and you need to monitor whenever they come back for that follow-up for you to see if their LDLs are responding appropriately after that 4 weeks, okay? Liver toxicity. This is rare. It can happen, so you're going to monitor their LFTs. You can see a bump that happens when you initially put a patient on it. I saw this happen in a patient. So just, again, something that is rare, but when it happens, it could be not so great for your patient. So you see that you're monitoring at baseline, the 4 weeks, which we already said we were going to recheck their CK at that point anyway. And then you see 12 weeks. So you're going to look at their AST and their ALT whenever you see anyone say LFTs. That's usually what we're talking about is going to be AST and ALT, okay? Again, don't remember the 3 times the upper limit of normal. I'm not going to ask you those numbers. I want you to remember what you're monitoring, okay? So when you look at this, this is a summary telling you of what you need to do and when. So at baseline, I'm getting their lipid panel because that's what I'm trying to fix, right? Their LDLs are bad, so I need that. Then I'm going to get the LFT, so my AST and my ALT. And then I'm going to do my CK because I needed that. Now, when you look at your 4 to 12 weeks, this depends on the provider. This also depends on the patient and what you tell the patient when you prescribe. What I like to say is, hey, if you start to feel any muscle issues, weakness, anything like that, come back to me or call me. Because if I have a person who is complaining of that, I will check their CK again, right? So if they're at an increased risk, if they're telling you they're having symptoms, that is when you check them. There is no time frame. This can be at any time. The patient that I was telling you guys about earlier, he was fine. He was taking a statin. He had been on it for, it was years. And all of a sudden his body was like, And he had rhabdo. Got hospitalized and everything. He said, oh, well, I thought it was from me working out because he was working out twice a day. He was working out a lot. And so he's like, oh, I thought it was from me working out. So not only did he have a family history of being sensitive to statins, but he also had an increased risk, right, of him having any of these myopathies because he was working out so much. But it ended up happening, he went into rhabdo. We put him back on the statin, happened again. So we were like, oh, now he can't tolerate statins anymore. So this can happen at any point in therapy. They can be fine and taking it for years, and then all of a sudden, their body isn't tolerating that statin anymore, okay? So at any point, if they tell you of any of these symptoms, you can always pull the CK. Do we usually do it without any issues, like if they're telling you that they're fine? No. So 4 weeks, because 4 to 12 weeks, remember I told you you can see that bump. It's rare, but we want to catch it. So that's why we're getting those LFTs. And then hepatotoxicity, again, any signs or symptoms, you don't have to just wait for that. Hey, I feel like I'm having issues. Feel like it might be some hepatotoxicity, and you're like, it's not 4 weeks yet. You got to wait 2 more weeks, okay? Don't do that, right? So anytime there are symptoms of any of these issues happening, you can always check, make sure you're getting all of it at baseline, make sure that you're not changing their drug again until they hit at least 4 weeks, okay? Let's take a break and then come back. So 10 minutes, everybody.
Were you at the conference? We were trying to get an Uber. Why isn't it out?
Okay, so on this, what I need you guys to be aware of is that juniors, y'all have had cards, sophomores have not had cards, right? So the way that I am going to word things, I haven't written your exam, I don't write your exams before I teach because I don't want to teach you a test, right? So I don't know how a question will look or all of the things. When we look at this, the idea is that y'all have a picture of kind of where to go. When you see primary prevention, this is saying that they don't have any type of ASCVD that was established. When you look at secondary prevention, they have it. Now, are there more nuances to this very high risk versus not very high risk? Yes. So typically, right, they've been diagnosed with ASCVD, and then let's say they have several of these or they have one of these with a high risk condition. There's several different combinations that you will learn in Pharm or in your junior semester that has not been learned over here in the sophomore semester. So when I'm downplaying this, I am downplaying it in a sense of I am in a Pharm lane, not a cards lane, and I'm talking to you more so about the drug, and the question will be realistic enough to where the sophomores don't have to know all of the nuances, and even the nuances that you know, you will still be able to answer according to the junior class, okay? So your question, it will still be a realistic question for you to be able to answer it, okay, without all of the super small details that we don't have over here. So I'm in a limbo with how I'm teaching things because of how the classes are now, the sequence of classes, okay? So be patient. I will not set y'all up. If the question comes out and it doesn't make sense, then guess what I can do? I have the power to do. I can give it back. So I'm not too worried. Okay, so we were here. When you look at things, because we already said like, hey, statins, a big side effect, and the thing that people have an issue with is going to be that myopathy that can occur. And so I want to know if I have a person who has an increased risk of having that myopathy occur to where they're not going to take the medication. So over the age of 75, right, we keep beating that they're over the age of 75. If they're a female, we're going to attack them, beat them down, right, because they're female. Renal insufficiency, hepatic dysfunction, thyroid issues, so hypothyroidism, any of these other interactions that you see here, right? So their diet, Asian ancestry, things like this are going to predispose my patient to having an increased risk of experiencing myopathy, okay? Now, if you don't turn around, if you do this every time, we're going to kick you out the class. We're going to send you outside if we ever talk about ethnicities or races. Stop that. We have people over here who look at people whenever we say stuff. He's just joking though. It's their little thing over here. All right. So your statin properties. I usually don't focus on the statin properties that increase the risk of myopathy because I'm more so looking at the patient characteristics, because this is something that I can control, right? The drug is already made, so I'm not going to ask you about stuff that's on this side of the slide in this sense, okay? So focus more so on these things occurring in a patient that would increase their risk of having myopathy, not so much the drug, because you can't do anything about that. I can manipulate and deal with and work around these patient characteristics. Now, if I have a patient who I have now discovered they are intolerant to a statin, okay, what do I need to do as a provider? This is a big deal for you guys, because you are going to be the person who they call, or you're going to be the person who prescribed the meds and I came back and told you I didn't take the meds because they hurt my muscles, okay? My muscles are hurting and I didn't go to the gym. So first thing that you can do is you can change the type of statin. You see that we have a pretty good success rate, and 30 seems low, but that's cool if all I have to do is just change it to another one, where the person will now not be sensitive. So I can change them from atorvastatin to rosuvastatin and they might be okay. They may still come back and say, that didn't work, all right? Then, so I kind of put these kind of together, but here you see you're changing your class. So let's say I was in a high, now I need to go to a moderate. I was in a moderate, now I need to go to a low. That's something that can also happen, which is similar to changing the dose, right? Not necessarily always the case, because I could be in my range, right, of what would be considered a moderate, because it's a range. So I could just change the dose a little bit and see if that helps my patient, or everyday dosing. And this one is last, because remember, if they're not taking something every day, they might forget it, and then that decreases our adherence, which then means that my results are going to be affected. So is this something that's possible? Yes. Just make sure that you're understanding. These are all of my options that I have if someone is intolerant to a statin. And then this is just telling you, like, hey, if there's ever any type of severe muscle pain that patient is experiencing at any point, they're going to need to stop their statin. What happened? Okay, I thought I heard beeping, but I thought I was going crazy. Okay. It might go out. If it goes out, just let me know, because it might go out. Let me know. So when you see this, if it's severe, there's no other reason, right? I didn't go to the gym, I didn't do anything, but all I know is I started taking this med, or I've been on this med, and now all of a sudden I'm experiencing these severe pains. I need to stop it, do a workup to figure out what's going on. I'll get their CK, I'll talk to my patient, do a UA, all of the things, make sure it's not rhabdo or anything more serious. Mild to moderate muscle symptoms occurring. Again, tell your patient, hey, you're going to stop it, you're going to work your patient up, and then you'll potentially start the medication back at a lower dose or start them on a different one. And then if a relationship exists, discontinue the original statin and let the symptoms resolve before you start to build them back up on the medication. So start low and then go slow on a different statin if you can, which was our first thing that we said was to change the statin, okay? So essentially, if you remember these up here at the top, you're okay, right? Change the statin to another one, change that intensity or the class of the statin, change the dose, or I can just say, hey, let me try every other day dosing for that patient, okay? When you look at some of our PK parameters that we have with our statins, when you see your renal function, most of the time if somebody has any type of renal dysfunction, we need to alter the dose of our statin so that it doesn't build up in their system and increase the risk of them having the myopathies, those horrible side effects that we talked about. But what you see here is A and P, atorvastatin and pitavastatin, don't require those renal dose adjustments, okay? So you don't need to worry about that in those patients. That is important because you might have a lot of patients who come in who do have renal dysfunction. So now you know you have two options that you can give to those patients. Protein binding. All of them are highly protein bound. The other P, so this is why it's important for y'all to remember which P you're remembering. Your pravastatin is not highly protein bound, okay? This is important if you have other drugs that are highly protein bound, because then you have your simvastatin, or any of your other statins besides your pravastatin, but you have your statin then competing with that other drug, and now the levels of either could be altered because now they're trying to bind at the same protein, right? And there's not enough. So somebody's going to lose. Somebody is going to get there first. So you see they may displace other highly protein-bound drugs like your warfarin. And then if you have that happen, it could increase the bleed risk of that warfarin because it's going to be more of it, it's going to be around free, floating in their body, right? Because it had to compete and it lost, okay? So atorvastatin, pitavastatin, no renal adjustment. So these are good for your patients who have renal dysfunction. And then when you're looking at other highly protein-bound drugs, your pravastatin is the one that is not highly protein-bound. Oh, that's the way you can remember it. It has PR, which is PR for like protein. So you can remember which P. Oh, okay. Sorry, I just saw that. All right. Your absolute contraindication, relative indication, contraindication in pregnancy. So this is what I was telling you about. A lot of our slides, you'll just see contraindication and it doesn't break it down for you. This one is more detailed and saying absolutely don't give it is an absolute contraindication. Relative is like, man, maybe I can alter the dose. Maybe I can do some things, but I can still give it to the patient. And then pregnancy, we'll talk about that. So your absolute contraindication, if they have any liver disease or any type of reason why those LFTs might consistently be, fluctuating or elevated, we don't want to give this to them because they might already have some type of renal or liver dysfunction that we're worried about, right? And we don't want to worsen that with giving them a statin. And we want to be able to know when it's our drug that's causing the problem versus their body causing the problem. When you look at the relative contraindications, this is if you're using it with certain CYP inducers or inhibitors. Again, I don't need you to remember the names of the CYPs, but this is just one of those relative indications that you see here. And then pregnancy. This is a risk versus benefit type of situation and a very serious conversation that you need to have with the patient. When you're looking at this, if you had to, you'll see a lot of the times where they might change the patient to pravastatin because it's one of the safest ones that we do see used in our pregnant patients. And again, that's PR, our same pravastatin that we talked about with the protein binding, right? So this, most of the time, patients should not continue to take a statin if they're pregnant. They're very nuanced things. What I want you to remember is the answer is no. Most of the time when we talk about it, the answer is no. If you had to in real life pick one, your pravastatin is your best bet. But again, OB, I don't mess with pregnant people. OB, hi, it's me again. That's me. I'm looking it up. I'm reading. I don't guess when somebody is pregnant. I don't guess when anybody is breastfeeding, okay? Because it's not just that patient. And then you see here again, nursing. It can pass into the breast milk. We already said that we don't usually give statins to people who are less than 19, right? It's an off-label indication. So that's why I also tell y'all just say no, okay? If they're pregnant, stay safe. Statin, we're not giving it to them, okay? Looking at our interactions that you have. So you have your CYP P450. Again, you see that we have that minimized whenever I'm using my pravastatin or my fluvastatin. This one, they don't go through those CYPs, so that's why you're less likely to see those interactions there. Grapefruit and grapefruit juice. Now, this is where they can see an increased risk of myopathy, which was the big deal that we were worried about with our adverse effects for our statins. When you see this, do they have to drink a lot of grapefruit juice? Kinda, yes. But that's not uncommon. Like, people like grapefruit juice. My great-grandma used to love, that was a long time ago, she used to love grapefruit juice, right? But some people still drink grapefruit juice or eat a lot of grapefruit. So, if you have atorvastatin, lovastatin, and simvastatin, these are the ones that are going to have, where you see an increased risk of myopathy happening in these, if they're taking these. And your atorvastatin is one of the common ones that you will see us use. So this one is like the one that you're likely having to worry about. But lovastatin, atorvastatin, simvastatin interacts with our grapefruit juice. Some people, they can drink a little bit, but because they already have potentially other risk factors that could increase their risk of myopathy, you can see this with a little bit of grapefruit juice, right? They just add it on top. So it varies. You'll hear some people, oh, they have to do so much. It depends, okay? So just remember, lovastatin, atorvastatin, simvastatin, increased risk of myopathy with that grapefruit juice. Red yeast rice. So this is over the counter that some people take as a dietary supplement. And what it can do is it can increase the risk of myopathy and rhabdo, especially on a patient who is taking a statin. So when you ask patients, what medications are you using, and you're doing your med rec, ask them specifically, are you taking anything over the counter, any other herbal supplements, anything like that? Ask those questions, because you're going to hear people say no, and then when you get more detailed, they'll be like, oh yeah, I do take that. Oh, and I take that. And then you'll have like 5 more things to your list, and they said they didn't take anything. Okay, so keep asking the questions, the probing questions. But red yeast rice is a very popular one that people think helps lower their cholesterol as it is. And so when you prescribe them the statin, they'll continue to take the red yeast rice in addition to the statin, and then they'll say that they have the myopathy that will usually occur. Okay, so just remember the things that are in bold, and you should be okay. Red yeast rice, we don't want it. Atorvastatin, lovastatin, simvastatin, you have an increased risk of myopathy. Pravastatin and fluvastatin, they're good for us to use if you have the CYP interactions, okay? Don't need to remember which CYPs. More drug interactions. These drugs that we love to use are interacting with lots of things, right? Your fibric acid derivatives, which we're going to talk about. But what you can see is that you can have the severe myopathy, right? Which we already said happens with our statins. But now if I add on a fibric acid to that regimen for that patient, I can see where they can have the myopathy or the rhabdo occur. Specifically, when you look at the guidelines, what they're saying is that gemfibrozil, you have a relative contraindication whenever you're looking at this. So we should not be combining these two things. We'll look at other options that we have to where we can combine it. Is it possible for you to see it? Yes, because it is a relative interaction, contraindication. Is it usually you who's going to do this to the patient? No, it'll be a specialist that does it, okay? Your niacin, again, if you're doing this with a statin, you see, again, I'm increasing. They all increase the risk of rhabdomyopathy, right? Muscle stuff, okay? That's all, I just keep thinking of these. Here are some of your other medications that we have on board. So your verapamil, diltiazem, amiodarone. We're going to talk about these when we look at arrhythmias tomorrow. Amlodipine. These are things that can also, again, in conjunction with the statin, increase the risk of myopathy. Does that mean that it's going to happen? No. Does that mean that it can happen? Absolutely. Okay? And when you stack on things, you increase the risk of that happening. So biggest thing that I want you to remember, because when we get to the fibric acid derivatives, you're going to see this same interaction pop up again. Your biggest offender that you have is going to be your gemfibrozil. When we talk about your fibric acid derivatives, you're going to talk about one of the drugs called fenofibrate. That's a better option for us to potentially use if we had to put a patient on both of these. Okay, so fenofibrate less than our gemfibrozil. This is a summary of all of the things that I just talked to you guys about, with an addition of ranolazine and ticagrelor, which we'll talk about in one of these blocks. I can't remember which one. Digoxin, we'll also talk about this tomorrow. So just remember the agent. I don't need you to remember what happens over here, okay, because this is a lot, the different types of things that you have to do. But just remember the agents, which you saw scattered throughout these few slides here, okay? So just your agents. All right, your fibric acid derivatives. So when we're looking at our fibrates, is what we typically call them, your mechanism of action, PPAR normally stimulates your lipoprotein lipase to break down or remove different types of chylomicrons, VLDL, which we said was the very low density lipoprotein. So this is essentially trying to say, hey, if I can do that, then I can decrease, so stimulate my lipoprotein lipase. Lipase is breaking things down, right? Lipoprotein lipase activity, which then can remove more of my VLDL, and therefore I can see a decrease in my triglycerides, okay? Because it's getting rid of my VLDL, which is the very low, okay? So the very bad one, right? We already talked about this in that chart. Best for lowering my triglyceride level. I do get some LDL benefit, but not a lot. when you look at this bump that can happen, you see where it says it could potentially raise your LDL if there's somebody who has a very high level of triglycerides. So because I am an agonist, right, that's trying to get those that lipase activity increased, what you can see happen is that there's a temporary bump now in your LDLs because I broke down my VLDL, okay? But it's something that ends up going away, but you can see that potentially happen if they have a very high level of those triglyceride levels. Good for raising my HDL, just a byproduct. Decreasing the progression of something that could be very bad for me, which are those lesions that we discussed. So your clinical use, what you're doing is you're using this in people who have high levels of triglycerides. I'm not going to go into detail about all of the different types. I'm just going to say that they have high levels of triglycerides or hypertriglyceridemia. Triglyceridemia, okay? High levels of triglycerides. Or if you see a lab level on my exam, anytime that I give you a lab, I will also tell you if it is high, low, or within normal limits. So you don't need to remember anything, okay? And if you see something that is high, you probably need to do something about it, okay? Good for my patients who can't use a statin. I'm just not going to have that good benefit or that response like I would if I used a statin for someone who has the issues with their LDLs. Looking at my agents that I have, so my fibric acid derivative, my gemfibrozil, good if I take it with food. My bioavailability of that drug goes up. I also have fenofibrate and fenofibric acid. These are just different types of the fibric acid that I could give, or different types of fibrates. Okay, so I have a fibric acid derivative, gemfibrozil. I have my fenofibrate and I have my fenofibric acid. Okay. Big things from there. All right, adverse effects. Now we see why these are interacting with my statins, because I still have muscle stuff, right? I still have my myopathy and my rhabdo. If I'm giving that gemfibrozil, more likely to see this with my gemfibrozil, right, than any of my other fibrates that I had. Headache, rash, mild GI type things, but not something that we have proven with this malignancy here. Monitoring LFTs, again, because of those muscle pains that we can see. You'll also see the CK if they complain of those muscle pains. You'll see that we can monitor the CK here as well. Pregnancy. So we said that we wouldn't be using our statins, but what you can see here is that if their triglycerides increase in pregnancy, you can give these medications in the second trimester if you needed to, okay? So fenofibrate, we like a little bit better than our gemfibrozil, but you say we can consider it, not something that is a must that you have to do. Our interactions, we've said this a gazillion times, right? So the reason why is it's inhibiting that glucuronidation of the statins, which then increases the level of the statins in our body, which increases the chance of them having the myopathy, the rhabdo occur to the patient, okay? So that is the why. Your fenofibric acid, this one is the one that we see that is least likely to cause that issue, even though it does have the side effect of myopathy on its own. But it is something that we see that we typically use, and it is safer, and we don't have that increased risk occurring in practice. Your warfarin interaction again, right? So increasing that bleed risk. And then your contraindications, renal or hepatic disease, we're worried about it because of the metabolism, and again, the issue with the LFTs, and then your biliary tract disease, okay? So these are all of your contraindications to why we would be using a fibrate. Niacin. So niacin is also our B3. What you see here with the mechanism of action is stopping your VLDL formation and secretion. So if I'm not making it and I'm not pushing it out or secreting it, remember our VLDL is going to carry that triglyceride around, so it's kind of like the school bus. So if it's carrying the triglycerides around, that can then be broken down to LDL, which is another problem for us, right? Now we are going to have high cholesterol, so we don't want that to happen. So what we see here is that end result is decreasing our VLDL, which then decreases the amount of LDL that we have hanging out. You see that we have great results in raising our HDL, but we are not going to prescribe this just to raise their HDL, but we're not going to prescribe this just to raise their HDL. Comparable to a low intensity statin. So if we were looking at this as a means of how we are trying to help with those with our LDL levels, it's not the best, right? It's a low intensity statin, but it is something that we have an option for. Good at lowering the triglycerides and reducing those coronary events, which is going to be very, very important for us, because usually when somebody has a coronary event, things start to go downhill. They start to end up on lots of medications that we don't like them on. Don't use this if someone is pregnant. Now, I keep talking to you guys about this chart, and I want to just make sure one more time that we look at this is something that you are likely going to see. This is summarized in several charts, which is why I keep referring to the chart and what we're going to choose for our patients to use, okay? So make sure that you're paying attention to this and understanding where you're going. Am I targeting LDLs? Am I targeting triglycerides? If I give you a lab value and it says high, like, make sure that you're covering everything that is possible for that patient, okay? Sorry, my voice. All right, so clinical use, most of the time when we're using this, it's because they can't use something else, right? So I can't use a statin. You see that I could potentially try to add this on with another medication to lower LDL. Most of the time, we don't see it happening a lot in practice. Now, these are the side effects that we were talking about as to why we don't see this used as much. The flushing that people experience and the warmth, and if they're lighter complexion or like someone who's white, their face will literally, like, they will turn red, and you will see like you will see the flushing, okay? GI issues, people will complain about like the cramping and the diarrhea that they experience from it. Increase in your transaminases, okay? So those LFTs would need to be looked at. So lots of things, right, that can happen when we're using this. The dose that we need to get to for these patients to treat anything is very high. So the likelihood, whenever I increase my dose, we always talk about we increase the risk of side effects. We increase the risk of these side effects. But I could potentially decrease the potential of this happening by giving them aspirin at least 30 minutes before. Do I like to give them a drug to help with a side effect? No, not ideal. But if someone couldn't, for whatever reason, take my statin, I could do that in this situation. I could also give them an extended release. I could tell them to take it with food, so that now that drug has to like kind of go through some stuff before it hits their system all at once. So we do have extended release formulations. Most of the time I tell people to just start with the extended release or controlled release of the niacin, because most of the time people are going to experience this. Titrating slowly, that is definitely a must whenever you're giving this to a patient. You have to start low and go slow so that their body gets used to it before you just hit them with their full dose of niacin that they would need. And then, of course, if they still can't tolerate it, decrease the dose. Potentially, you might have to stop this med and put them on something else, right? Liver toxicity, we get the benefit of decreasing the side effects, right, of the flushing and all that with the controlled release. But we now see that we can increase the risk of liver toxicity. Hyperglycemia. So this is important in your patients who have diabetes. So if they are uncontrolled, meaning their diabetes is not under control, they're not taking, I mean, you can have your diabetes under control and not be on meds, potentially, rare. But if I tell you that your patient has diabetes, controlled diabetes, that's fine. If they don't have controlled diabetes, so if I say they're uncontrolled diabetes, that is when you're more worried, okay? Because now you have something that's also going to throw those glucose levels out of whack. If I have them stable on a dose of insulin or metformin or whatever drug I'm giving them, their GLP-1, whatever it is, if they're stable on that and now I add niacin and I see a change, I can now change my dose. But if they're uncontrolled and I'm trying to control them and they're taking another med and I'm chasing all the things, you don't know what to fix first. When you're messing with meds, put on one thing at a time if you can. There are certain things in cards that we'll talk about where you're trying to put them on several things. But as little as possible so that if something goes wrong, you know what to fix. If you threw everything in at one time, you don't know what the problem was. So now you're having to pull everything off to figure out, okay, now are you better? Okay, wait, now are you better? So the slower that you add stuff, the better for your patient, for you to fix them. So don't administer niacin to your patients with uncontrolled diabetes. These are the questions that y'all like to miss on my exam, because it's this one word that will say controlled or not controlled. Or if I said that their blood pressure raised a little bit, you're like, yep, they have hypertension. That's not what that means, right? So read the words. Those things mean something, okay? So uncontrolled diabetes is where we're more likely to see this. Does it mean that it's a contraindication? No, it means that I'm watching out for it. So pay attention to that. And then hyperuricemia, again, this is just going to be because of the niacin not allowing the uric acid to be excreted, and therefore it can build up. And this is more of an issue with patients who have gout, which we'll talk about a lot of that in our gout patients as well, but it's more likely to have them experience a flare, which is not pleasant for them. This is just some of the things that we already talked about, right? So because of these doses being super high, you don't need to remember the doses, but this is just showing you like they're very high doses. But because of the dose being very high, it's hard for a lot of our patients to tolerate them. It takes us a while to get them there. But your contraindications that you see, your liver disease, gout, because again, how I told you with that uric acid buildup that could happen, active peptic ulcer disease, and any type of hypersensitivity to the niacin, meaning they're having that flushing, and no matter what you do, like they're still experiencing it, or they can't tolerate just niacin in general. That goes for any meds. You're not going to give it to them. And then monitoring your LFTs every 6 to 12 weeks yearly, just making sure that they're not experiencing that bump that we could potentially see more likely to happen whenever we're looking at our extended or sustained release. Bile acid sequestrants. So when we look at this, when you think about bile, bile is made from cholesterol. So after production, what happens is they're bound from circulation by these medications, essentially, and then that causes the liver to make more cholesterol to make more bile. So when you're looking at this, I'm going to bind to those bile acids in the name, right? Bile acid sequestrant. I'm going to bind to them, and therefore I'm going to lead to more cholesterol being converted into the bile acid. It's making their now liver uptake more of that cholesterol from the system floating around, right? Why I have high levels of cholesterol. And it's going to bind it and take it in and say, I need you to make more bile now. So bile acid sequestrant, okay? Now, what is important to tell people when they take this is that they're going to see the shell of this pill in their poop when they go poo-poo, okay? Because the resin doesn't get absorbed. So it's excreted in the feces and they see it, all right? And they're like, oh, my medicine, it didn't work. It worked. That's just how it comes out, all right? So pay attention. I tell you, things people can see, you need to make sure you tell them. So here are all of your bile acid sequestrants that you have: cholesterol, cholesterine, cosavelin. These are different things that we have. When you're looking at the dose, I don't need you to remember the doses of this. You see that you can use these whenever we're talking about our pregnant patients if they need treatment, because again, it's not something that's going to be absorbed. So this is also second line to a statin, just like we talked about our fibrates were second line, right? So remember, you have other options. Our statins are just the ones that give us those great results. And then you see here, these are good for our patients who are also pregnant, right? Because I can use these in my pregnant patients, all right? So remember the kind of the nuances, and then when you see a vignette, make sure that you're picking those things out in a vignette. Comparable, just like we talked about before, low intensity statin, minimal HDL increase, could potentially increase your triglycerides. So watch out in a patient who has high levels already of triglycerides, because this could potentially bump them up over the edge a little bit. decreasing those coronary events, decreasing mortality, all the benefits that we said that we liked to see. Looking at your clinical use again, so if they can't tolerate a statin, meaning second line, all right? But you also see that you can use this in patients who have diabetes, so this stands for type 2 diabetes, and then decreasing the half-life of some of our medications. So this is an example of us using a medication for the adverse effect or interaction. If I want this drug to be absorbed and out of my system or excreted, I can use these medications sometimes, and it can decrease the half-life of those medications. So it will push them out of my system faster. That's what a decrease in my half-life is. Looking at my adverse effects, a lot of GI issues. So think about this one as that resin doesn't get absorbed, it goes in their poop, it's also going to hurt their stomach. Okay, so I think of it all, it's all down there, right? So GI distress, you see that this happens in a great deal of the patients who are taking it. Up to 40% of your patients are going to not take these medications because of how bloated, gassy, and uncomfortable they feel from the distress that they're going to feel, the constipation. It is not comfortable, okay? Increased fluids, right, while they're taking this medication, and then you can try different things to alleviate the constipation, but not an ideal thing, again, because we're adding on a drug for a drug. Decreasing absorption of other drugs. So this is how I was telling you it's an adverse effect, but we're using it for that benefit if there's a drug that I'm trying to get out of my patient's system. So with that, if it's not a drug that I'm trying to get out of the patient's system, I need to make sure that I'm letting my patient know when they need to take it. So 1 to 2 hours before they take that other medication, or 4 to 6 hours after they have taken my bile acid sequestrant. Okay, I need to separate them, because if not, I'm going to interact with the half-life of that other drug, and it's not going to get to the level that it needs to get to. Here are some other drugs that you can see that it will decrease the absorption of, that we can potentially use it. Why these are listed are these are the drugs that you will see that people take, and they're taking them for a reason. They need them, and we will see that the levels get decreased. So warfarin is a blood thinner, right, that we need to have on for some of our patients. Thiazides, beta blockers, we're going to talk about these coming up here, but we use these for several different indications. And some people take, their vitamins and folic acid, ascorbic acid, also in a lot of multivitamins. So these are things that you can see happening with our patients. Contraindication, because I can see potentially that bump that we talked about. If somebody has a triglyceride level that's over 400, which is extremely high, they should not be taking a bile acid sequestrant, okay? So greater than 400, elevated triglyceride, highly elevated triglyceride. Make sure that you're understanding they should not have a BAS on board. Looking at your cholesterol absorption inhibitor, or your ezetimibe. Essentially what your ezetimibe is doing is inhibiting the absorption of cholesterol from any exogenous sources, right? So my diet and my endogenous sources, which is my body making it, right? So this is what we kept saying, hey, if your statin isn't working, you can add on ezetimibe. That's what your Zetia, okay? That's what we're adding on when things weren't working. So inhibitor of intestinal absorption of cholesterol and your phytosterols. Again, endogenous, exogenous, it's working both ways. Comparable to the low intensity statin, minimal HDL, minimal increase, or minimal HDL increase, minimal triglyceride decrease. And then your adjunct to a statin, which is what we kept talking about with this one. Also, we'll see sometimes where, I'm not going to ask y'all that. Don't worry about it. I'm not going to ask you this, so we'll stay right here. Adjunct to statin therapies. Pregnancy, again, we saw some adverse events, so that means no. And then your interactions, this is with several of our drugs, but if we're taking that bile acid sequestrant, the 1 to 2 hours before or 4 to 6 hours after the ezetimibe. And then you see the good thing about this is that if I did have a patient who I couldn't get under control with just my statin and I was going to add on the ezetimibe, that I have a combination product. So now this is just them taking one pill, or if I have a patient who is sensitive to a statin, I now have a combo product in one pill, and it allows me to decrease the dose of the statin that I'm giving them, because now I've added on my ezetimibe, which is equivalent to that low intensity statin. Okay, so this is an all around good option for the patient because they're getting their statin, they're getting the ezetimibe, but they're getting it in one pill, right? And they're decreasing the risk of that myopathy if that is the case for that patient. Okay, so great benefits with this. Your PCSK9 inhibitor. When we look at this mechanism, essentially, when we talk about PCSK9 is an enzyme that binds to your LDL receptor, and it can promote your LDLR degradation, so your LDL receptor degradation. What that means is now I have more LDL floating around in my system instead of being bound by the receptors. I want the receptors to be there. So I don't want PCSK9. So my drug is a PCSK9 inhibitor, right? It is allowing my LDL receptors to stay for a longer period of time to bind the LDL that's floating around. So now I can promote the degradation of the LDL because my receptors are hanging out because I inhibited PCSK9, all right? So that's what this is saying, that it is trying to stop that PCSK9 from degrading your LDL receptors on your hepatocyte, and therefore now I can bind more of my LDL out. So just remember the underline. It'll be very similar to this if you see this on the exam for your mechanism of action. Results overall, getting rid of more LDL out of your body. So I'm decreasing my LDL levels, which is what we want. Looking at your use, good for my patients who have high levels. We saw this in our very high-risk patients who we were looking at our secondary prevention. This is where you can see us kind of jump to this. The thing with this is it is more expensive. You can see us use it in conjunction with a statin. You can see us use this without a statin and just put a patient on this because they can't tolerate that statin. So several different options that we have in using this, okay? We have they're newer drugs, so we're getting more data that constantly comes in, but we have a mortality benefit that we see here. We already talked about using it with a statin. Adverse effects, most of the time what we were seeing were like injection flu-like symptoms happening in our patients. So injection site reactions because people are going to inject themselves with these, which is why they don't like them so much. So you have your alirocumab and your evolocumab. When you're looking at these, you see they're both sub-Q options, but the big thing here, look at how much money this costs, right? These are not cheap drugs. So that's why you don't see us going to these first. These are more like reserved for patients who can't tolerate a statin or who can't tolerate some of our other meds, or they're tolerating the statin, but we're still not getting them to goal. They're not at their LDL goal yet, okay? So they're stored in the fridge, all the things. What I want you to remember, the name of the drugs, that these are injections, not tablets like everything else that we talked about, and they're expensive. So these are like last line things that you're seeing us use these for. They're not commonly used unless you are not getting to goal. Now we have our omega-3 fatty acids. So you have your EPA and your DHA. They can get these from their diet. Most of the time you'll see us add these on. They're safe to use in our diabetics to help with target the triglycerides, because remember our niacin we couldn't use if they were uncontrolled, right? But here you see that we don't have any issues with our diabetic patients because it's not causing their glucose levels to change. Good for lowering your triglycerides. I'm not going to ask you about this mechanism of action, but just understand, good for triglyceride levels. When you're looking at your prescriptions that we have two options. You have your omega-3 acid ethyl esters and your icosapent ethyl, which is your Vascepa and your Larvaza. These alternate on who is on the formulary and who is not on the formulary. So TRICARE formulary lookup tool is going to be very beneficial to you when you're looking at these. Adverse effects, you see here with your omega-3 or your Larvaza, which is the one that we commonly are prescribing, they have a fishy smell and they're going to have a lot of gas. So they do a lot of burping. And so when they burp, it smells like fish. So a lot of people don't like that, so just warn them of that happening as far as these adverse effects. Higher the dose, the more likely you are to see an increased bleed risk in some of our patients. And then this could also affect some of our women who are pregnant, but Not going to ask you in that sense. Remember your adverse effects. Remember that you have two different options that you have. This one has the EPA and the DHA. This one just has your EPA in it. This one, again, helping with those triglyceride levels. Same thing. I'm not going to ask you about the pregnancy stuff. You do see that we have over-the-counter, right? So we have omega-3 that is over-the-counter. They can just go and buy it as a normal dietary supplement. But again, they still usually have those same adverse effects. So remembering these are good for you to remember for all of just this entire slide. You'll see this. Be cautious in the patients who have fish or shellfish allergies because they do they can potentially have a cross reaction, okay? So just make sure fish, shellfish, cross reaction. Oh, I'm going to finish y'all. I'm sorry because I want to do this tomorrow and I'm trying to get y'all out early on Wednesday too. So your Metamucil, laxative that we had that has a potential of decreasing LDL levels. That's all I need you to know. Don't remember all that other stuff. And then remember your adverse effects. They have a little gas, bloating, but some people take that every day. Not uncommon. This is just showing you some treatment options that you have. Just FYI this slide. I'm not going to ask you this. FYI this slide, okay? And then check on learning. So patient, which of the following medications is most likely to cause myopathy or rhabdo in a patient who is taking simvastatin? A, right? We talked about this one. Which one is my option that I would like that's least likely to cause that to happen? No, not in that way. Another fibric acid, another fibrate that starts with F. Phenylfibrate is an option that is least likely to cause this to happen, okay? 77-year-old male, boom, hypertension, presents to your clinic for a cholesterol screen. He's trying to take care of himself after recovering from his heart attack a year ago. He has high levels of LDL. His HDL is low. His triglycerides are within normal limit. What are we going to do for this patient? Right? So just make sure that we're looking at this. So he has the recent MI. He's older, right? So there's some other risks that are in there for that patient as well that's bumping him up as to why he ended up being a very high patient for us, right? Because I could just have one thing happen, and I'll try to make another, I'll try to see if I can make another simplified way for you guys to look at it. And the sophomores, I can talk to y'all a little bit more about it so that you can kind of understand it a little bit better. All right, our what do you know? What are some side effects of our niacin? Flushing, GI issues. What are our two high-intensity statins? The name? AR. Okay, what were my doses for my rosuvastatin? 20 to 40. All right, good job. And my atorvastatin? 40 to 80. Boom, look at that. When do we check our CK levels with statin use? Baseline, and then anytime, right? I don't see y'all talking next door. I'm not going to give y'all the memory joggers if y'all do that next time I'm over here. All right, so baseline and muscle pain. And then here are all of y'all's memory joggers. Go through here. See y'all tomorrow.